Hello, everyone. Thanks for joining us. We have a great case for you today. We're coming live to you from Winnipeg. I'm going to ask our first slice to be up, and if you can see it. If you can, let me know. Can you guys see my slides?
Yes.
Perfect. So, again, welcome from Winnipeg. We have a great calcified LAD case for you today. We'll do some calcium modification. Our goal is to be able to image the vessel and also be able to do some rotablation and potentially IVL if needed. Let's go to the next slide. So the case today is a 87-year-old patient who presented at the hospital with acute coronary syndrome and was brought to coronary angiography. And past medical history is really not really contributory. It does have a history of PCI to the RCA many years ago. And on angiography, you can go to maybe the next slide. You can see there is I think this is a cranial view of the LAD that shows diffuse calcium in the proximal segment and a couple of nodules of calcium right in the proximal segment. So which we think is the culprit. There's also some lesion in the circumflex, although it's moderate at best. Let's go to the next slide. You can see also the RCA diffusely calcified. Surprisingly, the stent in the distal RCA is patent, and hopefully we'll leave that for another day. Today, our goal is to be able to recanalize the LAD. Today, our team, Dr. Cass is with us, Arjun, our fellow, Sheila is nurse, everybody else is here, and we'll hopefully start. Our plan today was to primary wire first, see if we can actually get a balloon in there, open it up, and at least do some imaging to see what we're dealing with, and then subsequent to that, go with our 1.5 burr. Okay, so we're going to go with our universal wire, see how the lesion behaves. Patient's already heparinized. We have femoral access with a 7 French VL35 guide. There was a lot of tortuosity in the iliac. I don't know if I can maybe even show it to you later, but we really did need a braided armored sheath to be able to navigate that. It makes life so much easier. So we're going to go with our BMW. Can I get a wet one, please? Perfect. I always feel when you wire with the even a workhorse wire in some of these complex cases, allows us to diagonal there. That's just guys wants to go to the diag. Give me a little left there. And there we go. So what do you think, Malik? Do we balloon first? See if we can get an OCT across, or just go primary with?
I think you probably could try to get an OCT across first. If that doesn't go across, it'd be low threshold for ballooning. Don't want to modify it too much. It might throw you off with the interpretation of the OCT afterwards.
I could just tell like this wire doesn't want to move too much. I think the lesion is sort of hugging it. Couple of tortuosity. I like to get it as deep as possible. See if I can get it in there.
We'll get the OCT ready. Or let's get some contrast.
A little puff there. Just give me a little puff. I just want to see whether am I in.
You're on the right trajectory.
There we go. I think that should be good enough. I'm going to loop it down. The reason I want to make sure we get it as deep as possible, I'm thinking once we are in with our rotowire, I want to bury it deep. So perfect. Yeah, I'll give you some contrast. Go ahead. Should we try with the 2.0 first? Because do you think OCT is going to cross?
I would love to get the OCT across first by itself. Give it a good shot here. Okay.
Can we have the OCT screen for us open here so I can see it as well?
Am I out there, Arjun?
Yeah, you got contrast there. Oh, it's good. I just want to get some screen for the, so you can actually see the live screen of the OCT.
There it is.
Can you guys on MedStreamland see the OCT? I want to make sure you guys can see it.
Yes.
Perfect. Okay, let's see.
Failed attempt.
It was worth it.
Worth a shot. All right, let's get the balloon as our option B.
Let's go with the 2.0, see if we can get the 2.0 in. Yeah, our sense from the angiogram is the entire vessel is pretty calcified, although you can see some stenotic dilatation post lesion and is quite calcified as well. Just you can see the tram tracks on our diagnostic angio. I don't know if I can see it run. Let's see. So can you guys see the live angio with the cine running? You can see the entire vessel is heavily calcified with two spots that are quite two nodules of calcium. And I think that's where the OCT was getting stuck. We'll see how this balloon goes. Ah, not too bad. Little test there. I want to make sure we're hitting it right on the spot. Perfect. Let's go up there. I think I got it. Up. Let's go to 12.
That's an
Can we
impressive
go to
recoil.
15? Can I get 15? Okay, and down.
That'll
You
do the
see
trick.
yeah. Let me see how easy this goes.
12 and down.
Let's hit it again.
Up.
I'm going to go up with our 2.0 softy balloon here. Get some opening there. I think it's going up not too bad. Okay, let's come down.
12.
What do you guys think? Is there any osteal disease there that we're sort of fighting with that? Should I go up a little bit more? Hit it there?
I think the OCT should show that.
Okay.
Yeah,
Let's do
should we
that.
get the OCT through that? Give the balloon back here, Sheila. Get the OCT
Let's
back
try
on.
it.
Yeah, you got it. Yeah. Thanks, Jocelyn. I'll take that from you there, Arjun. I'll give this to you here, the Sheila. Okay, roll that out.
Let's try the
back
OCT
in.
again, see whether they get some imaging of what we're dealing with. Because in terms of, I think in the nemesis, most of us agree is having nodularity, especially calcium that's quite nodular, is going to be tough. I don't know what your experiences have been, Malik. What do you think in terms of what would be your go-to device if you had nodules?
Yeah, for nodular calcium, especially if you're not too deep. Deep nodular calcium could be a challenge, but calcium like this, I tend to favor the rotoblader approach. We have used some orbital, we've used some of the Diamondback with some reasonable success, but
I got it.
This tends to work out quite favorably as it shaves it on the way in. The other advantage I find with the rotobladers, you have a lot more tactile feel as opposed to the Diamondback. But I know other centers do prefer that as a first option. Still fighting you, isn't it?
I think we're going to get it across. Let's see. It's just the past the RX port. It doesn't want to go.
Yeah, it's always the RX part. You might need a non-compliant here.
Well, should we just rotoblade it and maybe do an OCT afterwards? It would be nice to see what nodules we have to deal with. Let me just do caudal here. I want to see if I'm getting stuck on something. Our guide is quite roofed there.
Yeah, you're stuck in the RX.
The RX part doesn't want to make that bend. So the LAD, we don't appreciate in some of our angio pictures.
Tortuosity.
Yeah, it comes off in an acute angle off the left main. So maybe that's why we can't get this thing across. I don't want to belabor the point. I think we should just do rota.
You're
open up the...
You get the microcatheter, please. We'll get a trapping balloon as well. Yeah, Turnpikes works.
Yeah, everybody has their own favorite microcatheter for these things. I find, at least with the Turnpike spiral, it makes you get around some of these angulated lesions. It gives you a lot more push.
Let's get a 275 trapper, please. Yeah.
Slush.
Yeah.
And now let's get the RotoWire too. I don't know if you guys have it. We'll wait for the trapper.
So what size should we start with here, Arjun? What do you think as far as rotoblader?
Probably take a 1.5 burr to start off with here. So, it's at least a 3.5, 4 vested, but it's pretty tight.
I think so.
Let's go to the 1.5 burr.
The other thing is most of us have sort of moved away from using 1.25s off the hop. So that's usually, I think most of our practices started, the lowest burr will go with 1.5 unless we have a very difficult time getting it through. Most of our cases, I think you could get a 1.5 burr through just to get enough room. So I suggest let's try the 1.5 burr first and then try to OCT again, see if you have enough plaque modification. The trap that I always fall into is we do the initial rota, assuming that it crosses and the calcium is modified, especially with nodular calcium. It's going to be hard to decide. Let's go up there.
You're going to lose pressure here there, Courtney. Up at 12.
Yeah, we're up with the trap. I'm going to go with our microcatheter. Yeah, our wire's stable. You just see the distal end of it, so it's not bouncing around. Just let me know when you guys see the wire. Perfect. You can pin it there for me. Let's come down with a trap.
Trapper down. 12.
And this is the spiral we have, right?
Correct.
Perfect. What I usually do is I usually don't try to, just a little bit of a spinning motion, trapping the wire with my pinky. Couple of turns, see how it moves. And I think it's moving freely without much issue.
Beautiful progress.
And again, because I'm going to drop my rotor wire deep as much as possible, give myself support, make sure I drop it somewhere that's nice and deep so I'm not going to worry about. I think that should be enough. Okay, can we get some flesh on this thing? And I'll pull this out. Arjun can take that and just get some fresh for me. Perfect. Perfect.
BMW out. Okay, we could probably get the trapper off. This guy's long enough.
Sure. Let's do it. You can get a trapper down.
Get trapper's down. Okay. You want to walk it out?
Let me just see if I can make sure I don't pull anything else out. There we go.
Okay. I'll give it some de-airing. I'll give this to you here, Sheila. De-air the system. Every time we always de-air the system after the trapper comes out, as it does pull in air. Drop some air in. I'll give you the rotor wire here, there, Arjun. It's stiff coming out.
There we go. So we're going to go with a rotofloppy. I don't know what you're thinking is whether it's got a nice little tip to it. What do you think in terms of rotofloppy versus, I always feel this controversy of which wire to use. You do with the extra support, is the regular floppy. I think this one, mostly I think with aortosteal lesions when you want to rotoblate, those are the ones that you can definitely need support directing the burr into the vessel.
Yeah, I tend to agree with that. We tend to use the floppy for most cases. You can probably get away with a stiff case in this one, or extra stiff in this one as well, but we tend to prefer that for the osteo cases where you really need the support up top. That's looking good
for us. And I think we did enough modification. Let me just see if I can walk this back. When it gets to the braided part of the, or should I say the
spiral part.
The spiral part of the microcatheter, it does create a lot of traction. So you have to maybe walk it back, give it a nice little counterclock without pulling the wire back too much. Perfect. Keeping my eye on the wire. Walk it back. Yeah, I'll open this for you. Perfect.
So wet one for you up top.
Let's do that.
Yeah.
So we have our 1.5 burr ready to go.
I love the loop that you've got there, Amir.
I know, that's like, what's that? There we go.
All right. So I'm not sure if you can see up top where what we're dealing with here. We got the 1.5 burr going in on the Rotor Pro system.
Yeah, you can
Put that on there for us, Arjun. You typically want to start your control right in the middle there and keep it as straight as possible. Sorry about that, Sheila. I'm knocking people around here. Straight. Okay, got the wire here now.
Okay, so we can do the keep going a bit more. There we go. Let's have the Rotaglide running.
Yeah, we'll get our safety
Let's get some
assessment
flow.
going. Rotaglide open.
Perfect.
Wide open.
Yep.
Slow that down a bit.
Yep.
There you go.
Give it a try.
All right, you're high up already there.
Yep.
Okay, we'll spin that. We'll do our test spin. So 155, 156, you typically want to be good. Yeah, you want to be in the 150 to 160 range.
Do you want to do the single operator or you have it there?
You're
here. Let's do it.
We could do this way.
Yeah, you got it. You got the wire there?
I do.
Perfect. Let me know if I'm pulling too hard and if I need to stop. There we go. Makes a big difference with these 7-French guide. The 1.5 burr just flies right in.
Arjun, can I give you the rest here?
You got it? Come with me, come with me, keep coming, keep coming.
Pause for a sec.
Perfect. Leave it there. Make sure to take the tension back, nothing sitting in there. My wire's stable. I usually do a little. You can see that tension is still there a little bit. I want to see if I can get it in a bit more. Perfect.
There you go.
So you guys can have a look on there for me, see if there's any decels. And let's do some runs there. The pressure there is not the best. I guess this thing is.
Let's get stuck.
Let's see. There you go. That's what Arjun was trying to tell me. Okay, good. Let's do some runs here.
So obviously, as it's doing that, we're looking for decels. Anything more than 5,000 tells us that you're generating some heat and opening yourself up to thrombosis. So far, we're dropping to 150s, so you're ablating nicely. Okay.
Just tolerate it pretty good. Very little decel there.
Yeah, short pecs. That was beautiful. That's how to do it. You don't want to rush it.
You can see there's probably 2 nodules there, one in the beginning of it and one of the bigger ones right after. And I think the burr just got engaged in the second one. So we'll try to see if I can burr through that one.
There you go. That was nice. Nice polishing.
What do you think about that? Should we do another one?
Pretty good with that. What do you think, Arjun? It looks pretty good to me.
Should we try OCT after this? Let me just lock this. Okay, you want to walk this out?
Sounds good. You going Dynaglide mode or you don't need your 7-French?
I think 7-French should be okay. Sorry, let me just open this up. Copilot's acting up. It's locked. Can you take it out? Let's see.
Oh, I can start, yes.
Perfect. Go for it. Can I get one of those good co-pilots? Do we have one of those?
You want a Guardian?
The special ones, the good ones.
The Guardian. Yeah, it's the Guardian.
So we're coming out with a 1.5 bird. That's in pretty okay. We'll do a little test shot. Bird's going to pop out soon. Perfect. I got it. Sometimes if we're happy with the burr here, usually I leave the rotor there. Go with another wire. This thing is.
We'll just shut this down for now. Yes, please.
Just pull it.
What's that?
Yeah.
There you go. That's why.
Yeah, that's why I was saying that.
Well, it helps with the blood pressure, I guess.
You want
this?
A
little just. It's okay. Let's hold off. It looks like it worked. I was just pulling it in too much. Let's do a little puff. Make sure we didn't cause any excitement there. That's actually pretty good.
Yeah, it's good for the OCT for sure.
Should we put another wire and then just do OCT?
I think you can probably go through the OCT through this, can't you?
I think so, but it's just much more cumbersome.
You may switch over or just rewire with the second wire?
I'll just get another wire or universal wire, put another wire.
Yeah, let's do that.
Take a picture, and we'll get an ACT as well.
Yeah, we'll do this. Get the BMW ready for us, please.
We'll just leave our initial plan was to, if there was still very thick calcium, is to go with the larger burr.
We still reserve that option.
Yes. Hopefully this the OCT will be a tie break.
It's unfortunate we couldn't have a pre-OCT. It'd be nice to see what the cracks we got.
Let's do that. That's our original universal.
Yes.
The lucky BMW. So people classically talk about the duck sign as the burr is burning through. So I'm just going to leave this here. Wow, this thing is
too tight.
Back on. I just get stuck into that mode. Yeah, the duck sign, as it burrs into deep calcium, I really want to understand how thick the calcium is. And whether we need to do any aggressive burring, maybe with a larger burr. I think the biggest thing we did today was getting that armored sheath. Allowed us a lot of flexibility for guide control.
And look at this left anterior descending, you're probably going to be close to 3.5 or larger.
Right.
So you're quite safe going up to 2.0 on a burr.
Okay, let's try that OCT.
Here's the OCT there, Arjun. I'll give you some more contrast flush as you go in. Flush that, please, and get rid of it. Coming out?
Yeah. Let's do the OCT in there. Perfect. Hold the wire for me. We're going to hold on to one of the good co-pilots from now on. I got it. With me a little bit more. Moment of truth. See if it goes through. Oh, wow. I think it's the angulations that's really hurting us. Should we get a guide liner across and then see if we can get this across? Well, there we go.
What a bit of traction. If Arjun gives you some pull on the BMW as you're pushing.
Yeah, just pull the BMW a little bit and see whether I can straighten it out. No, it's just buckling the RX port.
I'll pull back the BMW more. You have lots of room. Pull. Yeah, it's not working.
Oh, almost.
There you go.
There you go. Give me more traction there. Make sure I don't pull that all the way out. It doesn't want to go in. Let me just push it in a bit more. If I can push it in a bit more.
Yeah, the angle is not favorable whatsoever.
Well, I think it just makes the first bend from the ostium and it just gets stuck there.
Well, you buy yourself more support now with a deeper wire.
I think he's just getting stuck on the angle.
Might have enough to image that first nodule close to.
Let's get a 6 French guide liner, please.
Yeah, let's get a 6 French.
The challenge with this is you're on a workhorse wire and the RX on that angulation on the.
Yeah, I can see the bend getting on there.
Yeah, so for those of you can see up top, every time you go into the short RX, it's just going to always recoil like that.
Leave that in.
Yeah, it's just 6 French will fit beside that. Yeah. Yeah, we're on a 7 French guide.
I think it gives us enough room just to get it through the ostial LAD. We'll.
How's our ACT team? Thank you.
Perfect. So happens in. Okay, let's try the guide liner.
Yeah, let's get this back on there, Arjun, after he's got control of the guide liner.
Perfect. I got it. Let's see how far this thing can go. Can it protect the proximal edge of it?
Yeah, look at that. It's
Oh,
beautiful.
I think we're good. Let's see.
Yeah, you should have the support past the RX point there. The RXs have a bit of a kink in it after our previous pushes, but
I'll be ginger with it. Let's see.
I'll give this the origin again.
So third time's a charm. See whether the thing makes it in. Perfect.
Exactly where we wanted.
Perfect.
Like butter.
I think that's deep enough for us.
Absolutely.
Just going to pull the guide liner back so it allows us to. What do you guys think? OCTing through guide liner.
Like with the guide liner inside?
Yeah.
We've done obviously it gives you lots of support to get the OCT through that. Not sure if you'd see through the guide liner if you image that.
I know.
I don't think that.
Let's do live view.
Yeah, let's have a look here, see if I have enough contrast to fill you in. Explore me there, please, there, Amir. Yeah,
Gonna get the guide in.
Love it.
Perfect.
Yeah, I should do it. No, let's go with automatic. I'm not sure why it defaults to manual on our.
I think the last time we used it was on.
Yeah.
Let's do auto calibrate.
So I'm assuming that they can see our screen up top there with the OCT run.
They can. Okay, enable pullback.
Okay, sounds good.
And we're going to cine and inject. Okay.
Beautiful. All right,
okay.
we'll walk this guy out while we
I think
register.
we got a good picture there. Going to come out with this. Make sure we don't get tangled on this stuff.
Let's go register this thing.
There we go. I'll give you the OCT here.
I hope I didn't take that last line.
Let's see what we see here. I think that's a good one.
Looks good, yeah. All right, so we can start off here quite distally. You can see the calcium already extending, deep calcium there, distal to the vessel of interest. Here's the area that we're coming to where we ablated.
Ooh, let's look at the nodule right from above.
Deep penetrating nodule all the way. You can't see anything past that.
And then not too bad after.
No, it's amazing. It really is focal. And there's that osteal part. The 2-hole bird through a 6-French guide liner.
Although we did publish a series looking at which guide liners can hold two burrs down really deep. Trying to get your, gotta write this wire one more time.
Sorry, Sheila, I'm going to put this over here.
Thanks. You don't need this anymore.
Yeah, I'm going to take that out too. Just when they're ready, we'll wipe it and put it in.
Okay. Yeah, so we'll do this part here.
I'm going to pull our universal out.
All right, so the RotaPro, as you know, comes pre-attached. And if you can change the entire system, obviously that's costs, or you can just change the unit per self. We'll open this up, make it nice and soft. And then we'll bring this guy nice and forward. to expose the copper. I'm not sure how well it's going to project. So we'll pull the copper back. Then pop it off. It comes off. It slides nicely on there.
Oops, sorry.
Arjun, you've done this before, I'm assuming?
Yeah.
Okay. I'll let you put this on.
Are we going with the better eyesight? Is that?
Yeah, he's younger. He's got better eyes. I can't see. I don't have my focals on.
You steer for the old system.
Get out of your way here. Beautiful. Run the copper over it.
Yeah.
And then bring the copper back on that.
Yeah.
Bring the copper back that way. This one, so you can see.
So you can expose the teeth.
Slide the copper all the way over. Good. Now see if you can just pull it off. Yeah, so it's not on solid enough. So you can't see you need to see the teeth. Push the copper in as much as you can.
How you doing?
You
can have a nice snap. No worries.
Tap this with your left hand.
It's working great.
Yeah, and your right hand pushes the copper off to expose it. There you go. Just make sure your feet are on right, so your feet might be off. That looks good there. Bring the copper
on top. You don't pull it back, just put it on and then push it in.
Did it slide on? No, it didn't slide on.
You want to do it?
I can't see at this age.
I can do it. Yeah, let me do it.
Yeah,
let me just quickly do it.
All right, let's get this guy on.
Yeah, you're perfect. You got it. Perfect.
There you go.
Good. That OCT's excellent. Okay, so let's try this 2.0.
Okay, let me just move it out there. Good. Yeah, there you go. You got full control. Start in the middle again.
Let's see. I'm going to wipe this RotaWire. It's kind of a little bit dirty as we're doing other things.
And the RotaWire likes to be really wet. Remember, it's a smaller wire. You have the glide coming your way?
Not. Oh, yeah, we got it. There we go. You can just dump it on my hand. There we can.
Okay, we'll keep this straight for you as much as possible.
I think calcific modification is always good to think up front in terms of what our next step will be. My feeling is this 2.0 burr is going to make the lumen a lot larger, but the deep calcium is not going to be as easy. You might have to resort to IVL, but what is your thinking about IVL and nodules?
Good. Yeah, the results are suboptimal at best.
You just pin the wire there for me.
Yeah, I've got the wire.
Just a little bit more tension for me. Keep pulling, keep pulling. I got it. Perfect. Let's test it. Let's make sure I didn't.
All right. Okay, coming on.
Perfect.
161. We'll accept it. We'll accept it. Glide is dripping.
Glide is dripping.
Okay.
Let's make sure. Perfect. Let me know when I need to slow down.
Yeah, I'll hand it off to Arjun in a few seconds. Between two of us, we have very long arms. Here it comes up nicely. Yeah, bring it up and release the tension as you did last time.
I want to make sure this is mobile. And then I'm just going to do a little.
Beautiful.
Perfect. Oh,
there you go.
Here we don't. Get it a little bit closer. Good. Okay, you guys let me know if any D cells there.
Yeah, somewhere in the 140s. Yeah. We'll take our time. It's a large burr. Working well so far.
Give it a bit of a rest. Sometimes I start with the biggest burr because that's probably going to be the most amount of particle generation. And as we slowly start shaving, then the particle generation gets less. And then let's try it again.
Get our left hand down there at some point, please, guys. We're going to rotablate her middle finger. You're making progress. You might even be
We're
past
almost
it.
through. I think we're through. I'll do another polished run.
Can we get our left hand down, please, guys? Left hand down. Her left hand's on her chest.
Perfect. We'll do another polishing run and we'll. I think we're totally through.
Yeah, I'm not sure I go much more than that because the distal vessel is a bit smaller.
Okay.
All right, let's walk it out. Now, this is in a 7 French. It might be easier just to glide it out.
It's super smooth that it went in. Let's see.
Just glide it out for fun.
Yeah.
Okay. All right. Arjun, you want to do this? Or you want me to do this? Yeah. Break the feet, walk out.
Yeah.
Spin, break the feet, walk out. You want to switch over to a workhorse wire or work on this guy?
I think let's do a workhorse wire. It makes life a lot easier for me. Just push the wire in, push the wire in. There we go.
Let's get the turnpike ready, please.
Rote?
No. Keep going. No, I'm just going to wire it again.
Oh, with a brand new wire?
Yeah. Okay, we're out. Let's get the universal. We'll just.
He's going to do primary wiring. It's fine.
Yeah, I was going to primary wire. I doubt there's any. We'll do a little puff, make sure.
All right, Arjun, you're up for the puffs there. Well, get the stuff ready for you. Okay,
Little puff there.
Intro tool, please, and a balanced middleweight.
That looks pretty good. Okay, let's go with our BMW, and then we'll rewire. And at this point, I think I'm going to try a 3.0 NC, see how it behaves.
You don't want to do the OCT again for fun? We need to see what happens to that.
I like it.
That nice nodule.
Even with a burr.
We need to show the difference.
I think so. Let's see whether we can.
Start getting that on. Yes, he's got the intro tool still in.
I think he does.
I still feel it's hugging the wire quite a bit.
One advantage of the balanced middleweight with the non-jacketed wires that you can feel that tactile feedback.
For sure.
Which you lose with some of the pilots and whispers.
Let's try that OCT again. Do we need to go the guideliner route, or do you think it's going to go?
I have full faith in the 2.0 burr. Not that it changed the angle of the left anterior descending takeoff.
And I think the RX part of this OCT is taking some hits. We'll see if it crosses again. I got it. Let's see. Using the rotaburr as a buddy system. Yeah, see, I think the angle is just not favorable for us.
It's also, to be fair, it has been also kinked a bit from our previous attempts.
I'm trying to do a pull back on the wire.
Oh, looking good.
There. It's getting stuck there. It doesn't want to go any further.
Complicate your life.
I think I want to see if I can gingerly get it across. There you go.
Wonderful. Good
okay,
technique.
I think that's good enough. Let's do another run there.
Okay. Let me get the guider in there if you don't mind there, Amir. There you go.
Perfect.
Ready?
Okay, let's do it. Let's go.
Let's enable. All right.
Ready?
Yeah.
I think I like the way at least angiographically, where the nodules have gone.
You think that's just wire in the midsection? Wire flow, or is there something going on there?
We'll take a look. Hopefully, should we go deeper with OCT?
I think you're there. I would.
Let's see.
Go reg this for now. Thanks, Christian.
Perfect. Let's accept it there.
All right, let's walk this through here.
Left main looks good. Also
very
looks good.
Look at that.
I think there's a pretty impressive amount of ablation there, because compared to what we had before.
Look at that. You've smoothened out your nodule. You've created a circular lumen to a certain extent. Your nodular calcium, which still comes in around 9, 10 o'clock. Quite impressive.
Is there a crack at 12, or is that just a wire shadow?
I think that's a
or maybe it's at 9 o'clock.
9.
Yeah, crack at 9.
It's your rubber ducking.
Yeah.
What's your rubber duck?
The rubber duck sign, yeah.
Yeah, rubber duck sign.
Okay, let's see if I can get the OCT in a bit more. Just get a better image. Let me get my wire in a bit more. Get my OCT in a bit more. Just to see if there's any concerns regarding that distal segment. It's really tight in there. I don't want to buckle the catheter. Yeah, I think it's going to be almost there. I think the bend is just really fighting against us. I don't want to push it any harder. I don't want to get it stuck. What do you guys think? Balloon time?
Yeah, I think so. Yeah, 3.5 and see. What do you think?
Yeah, let's go with the 3.5.
Yeah, 3.5 non-compliant, please. 15 or so. All right, Sheila, I'll give you this back here, please. Yeah, that looks good to me.
Great. Just get the wire as deep as possible. I think we're done with the rota. What do you guys think?
We're not going to go to too bigger than that. We're not going 2.2. So
there we go. So we're out with a 2.0. We're out with the rota wire.
Yeah.
I'm going to hand
Then
out.
I'll give you this, buddy. All right, rota's out. Let's get this out of the way.
You can show the hemodynamics too if you guys want to look. SCs are good. Bit hypertensive.
How's she doing? Looks good.
Great. Let's see how this goes. This wire's gotten. There we go. It's got some fatigue on there. I got it. A little puff there. Just want to make sure I'm going to hit it right at the spot. Come back a bit. Okay, let's go. Let's do it.
Up.
Let's go to 12, 14.
That looks well expanded.
Just get a zoom in on there. And down.
14.
I think it's a bit constrained there. What do you think?
Just looking at the vessel here. The vessel up top is about
we attempt an IVL just to make sure,
Or shocking.
because it's not circumferential calcium. I don't think IVL is going to help us much.
I don't think so. It's nodular, right? It may not help you much. So we're getting like about 4 by 3.2 there. It's probably going to be bigger than that. And you have lesion going down to the ostium, as you mentioned there.
Should we do a caudal view just to see? But on the previous angio, it looked okay. Like even our OCT looks pretty good.
Right.
So I'm assuming it's probably a 16 millimeters. You want to measure the length of their lesion? How long of a stent, if we're going to get to it?
Yeah, so there's multiple ways of measuring that. Obviously, you can look at the markers up top. We can do a more accurate measurement this way. So as I move down here to the ostium, you're taking 22.
I would spare the ostium if you can. Just let's go to the
prox lesion. You're looking at 15, 16.
I was thinking about a 3.5/16 stent.
Yeah.
Should we do a cutting balloon?
Not exactly sure how much benefit you get out of a cutting balloon at this point. You're nodular and you've already broken the nodule.
What do you think about the NC expansion there?
I think it was good. I think you're going to end up closer to 4.5 here when you're done.
I think so.
So
okay.
3.5 is reasonable. The 3.5 stent with the Promus will take you to 4.25.
Yep.
We could go with a 4.0. That'll take you up to, it gives you lots of room to go up to a 5.75. Not that we're planning to go that big.
Yep.
4.016.
Let's go with a 3.5/16. You want a 4.0? I'm swayable. I'm not committed to the.
Let's get a 4.016.
Let's get a 4.016. Yes.
Let's get that.
We can get another round as well. Another round of sedation as well. Perfect.
Yeah, Dr. Gupta's on that.
How you feeling? Yes.
It's going real well, ma'am.
Christian, can we get another round?
Let's get one for the patient too. Here's the ACT on the corner there, senor.
Some nitro too.
Let's do some nitro. Let's do some nitro. Blood pressure's like.
Yeah.
Let's go with 200 of nitro as well. Perfect. Let's shoot it in. Perfect. Let's go with the stent. I'm going to leave my ANC up as my landmark of when to land it.
Brilliant.
As part of our practice.
Oh my gosh.
As part of our practice, we always measure the MRCD for every patient, and we have it right in front of us, just in case there's so many things going on. We always have a look at our amount of contrast we're using. So far we're doing pretty good, and there's really no limitations in terms of our MRCD. Well, I think that's one of the things is changed our practice, at least over the past 4 or 5 years, getting a bit more
conscious.
We'll look at the, there we go. I think that's a little puff there, please. I want to make sure we're hitting it right at the spot.
Yeah, your distal's good.
A little puff again, please. Should we do caudal?
Yeah, have a look at the proximal.
I can't really. A little test there.
Brilliant.
That's pretty good.
Yeah, it's brilliant.
I think it's a go. Okay, let's go up. 2, 4, 6, 8.
Up.
10, 12.
Nice expansion.
Yeah.
The nodular at midnight
to
looks like
14.
it's fighting you a little bit there.
Yeah.
Yeah,
Let's keep it at 14. Let's stay up for 30 seconds. Make sure we.
Take a shot at that with Cine potentially.
Yes. Okay, let's do a Cine here. I think it looks fairly good.
Much better than it could have.
And down. I think that
14.
2 over made a difference.
Absolutely.
Although I'm always apprehensive about
Using a large burr.
nodules or large burrs.
The question that always comes up now is you've got a lesion there, you've got some recoil, post dilate or OCT again.
Let's see. Puff there for me. Let's make sure we have any excitement anywhere else.
That looks brilliant.
I think it looks pretty good. I would say let's just do an OCT. Save contrast. Let's do an OCT. And then takes a second guessing away from whether we have enough expansion of our stent. I have been fooled before, especially on the single angle angios, to think that the stent is expanded.
Do you want the guideline or?
We got it last time. Let's see. Hopefully with the
Stent straightens out.
stent in, we change the morphology of that ostium. There we go.
Be interesting to know what other labs use to displace blood as opposed to contrast. Historically we've used contrast. There's other options obviously out there. Saline typically doesn't do the job well enough.
You can look. I got it.
There you go, Jim.
Let's see. It does need that traction to straighten it up a little bit to bring the RX part down. As I do that, it does make a difference. Let's see. Now it's the part.
Looks buckled.
No, it doesn't want to go.
I think you're buckled in the aorta.
Let's see if I can change the angle of the guide, maybe.
Pull it up and clock it. Looking good.
Let it free fall a little bit. No, it just buckles more.
Looped in the aorta.
Let's go back in and try this part. Nope.
Guideliner?
Guideliner. Yep.
Guideliner, please.
I think because it's such a large left main and there's a bit of angulation preventing the thing from forming smoothly, so it just buckles into that space.
I think she's happy. Lovely. Thanks, Christian.
Let's get the guideliner. Can we give him make sure the jaw thrust or
We're big fans of sedation in our lab.
You can ask her to take some deep breaths. There we go.
So the guideliner will help you straighten it out. The OCT back in there.
There we go.
Over time, we've become much more heavy into imaging as well. The data has been quite clear on the benefit of that.
I get the guideliner in. I'm going to lead with the front end of the OCT. I think we got to get an OCT. This catheter looks pretty buckled here. We can look at the wire go. Can we get another OCT? The tip of it, this one is. What do you think?
Yeah, I think you know another one. Your property, yeah. Let's get another OCT, please. Yeah, you got it. Want to try this while you're waiting?
Yeah, let's do it.
Come on, Arjen.
I just don't want to get a kinked and lose a tip on there.
Yeah, I think you're probably okay as long as your guideliner is in nice into the stented segment. Once you're past that acute bend, I think you're probably okay.
We're getting close to the end of our hour. I want to make sure at least we show this final. This in before I
just bring it on standby there, Christian. Yeah, open up the.
Oh, I got it.
Here you are, Jen. I'll give you this again.
Perfect. Let's see if I can get my wires untangled so we don't transmit the loop right into the.
Just straighten that out a bit there, Jen, for him.
There we go.
Beautiful.
I think that part is a good part. And again, I'm very cognizant about not damaging my stent. I'm not 100% sure how it's expanded, so I want to make sure. It's a hard time coming out of that loop when I kink it.
Any traction on the wire?
Yeah, let's do that again. I think this OCT is fatigued here because I'm really don't want to.
I think we're getting close to our hour, Amir. I think you're right. Let's get a new one.
Let me give it one more time. It's coming with me a little bit. Let's get the guideliner in deeper.
Oh, beautiful.
I think
beautiful.
What we don't see is the angle of the guideliner going into the LAD. It's pretty tortuous, I think. Because now I think the tip of the catheter is fatigued on the OCT. Let me give it a bit more oomph there. It's one more time. Good old college try.
12 times the charm.
My worry is we get in this. No, it's not going to go.
Okay, let's get the next one, please. Please, yeah.
Yeah, I think it has no pushability. Like any push I give, it's going to buckle the RX part, even in the guideliner. One good thing is the wire is moving very freely now.
The contrast surge. Yep.
Yeah, I'll trade you there, Arjun. Get that bad boy on for Dr. Avandi then. Coming your way, young man.
Do you want to wait for more?
How am I doing, Arjun? Am I out yet?
So it's
We could get a body wire in there too, but
I think you're right. I think you just had tip fatigue. This should go nicely.
like this is the third time you've
On the
used
side
the
for
other
now.
one. So I don't traumatize it as in any way, shape, or form. Goes in nice and smooth. I got it. Let's see. Yeah, it looks fairly nice and comfortable going in. I think it was because of this RX point, it was actually rubbing in the guide as it was going up. It's a hard time going in. I think that angulation is not helping it. Let's see if I can get the guide liner a bit deeper.
You might need to pull back on the wire here.
Yeah.
Some sort of traction because you're in the stent. That's bizarre, isn't it?
I think it's the angle coming off the left main is pretty angulated. Like it doesn't want to track within the guide liner because of his stiffness, although
Get the guider up a bit better.
let's change the interaction maybe. Get a bit more aggressive engagement there. Get our guide liner in, get our wire in. See how far we can go. Let's
Nice wire position.
I think there could be struts that are right there because I'm hitting the proximal right at the strut edge. And I think the catheter is having some interaction coming out right there. It just doesn't want to. Can we try a, let's get a 2.0 softy balloon. I'm going to use a GBAT just to inflate the tip of the guide liner, see if I can get it any deeper. Oh no, the old one's good.
Yeah, and we're running out of time, so we're just for the sake
Let's
of
do
what
an
the plans
angiogram at
are.
least. Let me get the guide liner back.
Get some air out there.
Up there.
Yeah, very
You
good.
can have another 5 minutes or so.
I appreciate
Perfect.
it.
Let's just
Thank
do
you.
the angio now. At least we'll see what we have.
That's brilliant.
I think it looks really good.
All right, we got 5 more minutes. We can walk through what the GBAT process looks like as well.
Sure. Let's get the balloon at the tip in the wire. What I'm trying to do is get the guide liner tip, not to have any tip stent interaction. What we'll do is with this, we'll go up to about 4 or 5 atmospheres, get the tip of the guide, have a nice transition into the vessel.
Yeah. Torpedoes the guide liner. Surprisingly
Exactly.
softens the entry.
So what I'll try to do is get a guide liner where I can see the tip, leave it there, see how softy goes in.
Wonderful.
So that, let's go up to 6.
Up.
Let me know where you're 6.
Yeah, 6.
Now we just push the guide liner in.
Let's see if I can get the guide liner deeper in. Wow, it doesn't want to go in at all.
Might be a function of your angulation of the guide now.
You can trap the guide liner in.
You do that, risk of injuring the ostium.
Down.
You know,
6.
bring back the balloon a bit more. Just put the tip out only there, a bit less out.
Balloon, there we go.
Try
Let's
that.
see if I
Track it now that you've centralized it a bit.
could have done that earlier.
Now GBAT that.
Let's go up. Let's go up to 6.
Come back a bit in the balloon there, just so you torpedo the tip.
Up.
Beautiful.
Let's try that again. Oh wow, that thing does not want to advance. Okay, you can come down.
6.
What I'm going to do is try to even get the balloon distal. Let's see if I can just track the guide liner through it.
The advantage you have once you're in the stent is you could always switch over to a larger balloon.
Let's do the OCT now. I think we have enough, at least from the proximal edge of the stent we're away. Let's try it one more time. The other thing you can do is just do another body wire. I know it's old technique, but I still like it sometimes.
The body wire is a wonderful technique. It does
become so guideliner centric. Perfect. Let's give this a go with the freshest OCT that we have. It's getting stuck on something there. I got it.
All right, you got the nice.
You know what's happening is there's quite a bit of tortuosity. Hold the wire there for me again, Arjun. There we go.
That's with the armor sheath.
Yeah, it's really hugging the guide as it's going up. There's a couple of S bends down in the iliac.
Yeah, maybe before we come off transmission, show them the legs.
Oh wow, this thing. I'm impressed that this thing doesn't want to track.
You might have a bend in neck guideline that you don't see.
Yeah, you can see. Let me see if the guideliner goes in a bit more.
Yeah, it's right at the stent edge with the guideliner. I have to inch this in with the 3.5 NC again.
Yeah, I don't want to damage this, pushing it too hard. Let's go back to our working view.
Recall 2.
What about going with a smaller guideliner?
I don't think it's going to change your interaction much.
I know. It's like a acute bend.
I think you take a big balloon here, take the 3.5 back in.
Yep.
Let's get the 3.5 NC back. Do we have a 3.5 NC?
Should we get a short one and just trap it distally? Because I don't want to balloon it distally.
That's a good point. Yeah. How long is NC? It's a 15. Yeah, let's get it something shorter.
Like an 8.
That's an heparin.
Yeah, 3.5 or 3.75, whatever you have. Yeah. 5. 3.58 is fine. 5,000 heparin schnitz. You want to show the legs while we're waiting?
Oh yeah, let's do that.
Let's
flush the heparin in. I think the decision we made early on was to just going to floor. If you can go to live view, you can see there's quite a bit of angulation here, a lot of calcium. And this is already straightened out with our
stiff armored sheath.
With a stiff armored sheath. So made our guide engagement and delivery a lot easier. Yeah, let's try that and see. We're going to try to go into the stent, go up with the balloon, try to drive our guideliner through. I'm thinking I'm getting close to getting another wire down. I think because it's stent-stent interaction, maybe the guideliner is not the best. Can we get an extra support wire on deck just in case if this technique doesn't work?
There are lots of options there. Like you said, an extra support, balance heavyweight, the wiggle wire is everyone's favorite.
Yeah.
That'll be a nice bounce off.
Thank you there. Let's see if I can inflate this at a distal part of the stent.
You should do the trick if you get in there.
See, now with the stent in, it's really because we're hitting right at the ostium.
Might be easier to pull the guideliner back and go sans guideliner here. There you go.
Wow, that worked. let's go to 12. Let's go to 12. Perfect. So we're just sort of trapping.
There you go. And that'll centralize
come down for me with the balloon. As it's coming down, I'm trying to see if I can get it across.
An inch over it. Still fighting you, isn't it?
Still not there.
There you go.
Okay. I think we're good there.
Beautiful. All right, let's get the OCT back. That's wonderful. That's a nice.
So that jump tells me that it's not actually an obstruction. It's a lot of guideliner metal interaction inside the artery. And what it'll tell us also is that because it's a bit of an osteal stent, likely that we didn't traumatize our stent or accordion any bit of it.
Danny, Richard, how much time do we have left?
And it just
lost them.
yeah, we could be just done live now. If you let us know if we're still live, then we'll.
We will switch now. Thank you very much.
Okay, thanks for joining
Appreciate it.
us.
Thanks.
This was a great opportunity. We'll see you guys on the next case. I got it.
It's a tough case. Great result so far.
You are clear. Thank you very much. Great job.
Thank you.
I appreciate it. Thanks, Danny. Okay, Amir, you're on your own, buddy.
Thank you. Wow, this thing is really getting